Hello, everyone, and welcome to the December 31st edition of Beyond the Data, the very last one of the year. Yes. And today we have with us Dr. Beth Laffay from Elite Wellness Group up in Sandusky. And it's been so long since I've seen you.
Good to see you. I know. Hi, everybody. It feels really good to be back with you, Catherine. Thank you for having me.
Well, of course, whenever you can, I'm always game for it. But of course, we keep like entirely different hours. We live on different planets. I live like a vampire. You live like a normal person, and it's
It's a little tough. Yeah.
It's a little tough. And of course, you've been super busy. You've gone and you ran an election and you actually won.
Yeah, I did a thing.
You did a thing. You did a thing. So yeah, you want to talk about that a little bit? Your thing that you did successfully.
Yeah, I live in Huron, Ohio, and we had 3 open seats on our school board. I ran with 2 other conservatives, and one of the 3 of us got on. So I am now an official school board member. Yeah. So.
Of Huron City Schools.
Huron City Schools in Huron, Ohio. Yeah. I shouldn't say official. I guess I get sworn in this coming Tuesday. But the mask thing is starting to really become prominent again. I know for some people it's been all along, but for us, we've had the luxury of having it be optional. And it's coming up immediately along with a lot of stuff that's unique to our district. Like we have to pass a levy and hire a new superintendent and a new treasurer and, just some things. So.
Yeah. And I just showed you that Ohio Hospital Association letter there. Sorry about that.
Yeah.
Sorry.
That is why we're getting new letters about requiring masking. But yeah.
Yeah, that came out on December 28th, pretty much out of nowhere. Ohio Hospital Association put up this lovely letter basically threatening schools. Oh, we all have to go masking as quickly as possible because they're talking about pediatric hospitalizations have spiked in New York City. Pediatric hospitalizations jumped by 395% in December. So everybody here, in New York City, you can't go to a restaurant without being vaccinated, even if you're 5. So why are we talking about? But you must mask. All schools must mask at this point.
I love how it's underlined in blue that masks work.
Oh,
underlined
yeah, I didn't notice that.
It out. Yeah.
It looks like it's a link. Oh gosh, I should follow that rabbit hole.
For that, some scientific evidence.
Now you become curious. Oh, why? Oh. Now we can go down the rabbit hole. What this is going on about here? It's ODH saying why masks work. This should be fun. Why masks work?
Mm-hmm.
So yeah, if people want to go find that lovely letter from OHA, you can learn from ODH why masks work. I didn't even notice that. Oh, great. All right. So actually, before we should go on and talk about what you've been seeing, because you're a doctor, you are an ER doctor and functional medicine doctor. You've got your own practice out in Sandusky, and you're also in the trenches in the normal situation out there. So, I mean, that's the one thing I really wanted to talk to you about as well, because I just look at the data, I see what the data is telling me, and I hear people tell me their anecdotal stories and stuff. But I mean, you are absolutely the best source for that kind of stuff. But before we get there, I gotta, do my little advertisement thing here, because we haven't seen each other in like forever in person, like maybe May, was it?
Yeah, I'd have to think, but yeah, it's been some months.
It's been a long time since we've seen each other in person and stuff, but we will be seeing each other on January 22nd, along with Warner Mendenhall and Mitch Marcheski and the Ohio Stands Up crew and a whole bunch of other people. So if you guys, anybody watching, wants to see us in person, get to see each other for the first time.
I know, it's going to be great.
You can go to Ohio Stands Up and get those tickets.
And for a good cause. It's for to support people who are going against the mandates and actually filing lawsuits to help with their legal fees. So,
yep, no, it is a really good cause. I mean, and that's actually a really big problem with these cases that Warner is bringing is that they're expensive to do. And yeah, we're all going to benefit when those cases get pulled up. So it's all for a good cause. So now that I've done all that original, groundwork kind of stuff. So tell us, what have you been seeing in your practice, in the ER and all that for the last months?
Yeah. I think, kind of toward the end of August, I noticed, maybe even mid-August, I noticed a trend that people who last year could fight this off, and it was literally like a couple days of sniffles, were going on and progressing more often, like young healthy or older healthy, that were able to like just, kind of brush it off before. It's been a little bit more intense, and not necessarily more deadly, but more intense symptoms, more days of it, feeling, it's long. When you're used to being healthy, 3 days feels long, and 14 days feels like forever. So I've definitely learned to be more aggressive with treatment, outpatient treatment. We've stepped it up to the current FLCCC dosing, which is not new, but it's new-ish. It's 0.6 milligrams per kilogram of ivermectin. Fluvoxamine has really made a resurgence. I don't use that a lot. I mostly use it in post-COVID symptomatology, but the case is getting stronger for that. And still use hydroxychloroquine. And then a lot of supplementation, higher dose vitamins, and just really encouraging people to take care of themselves. One trend I've really noticed is that if you are an inflamed individual going into it, then you tend to have worse inflammatory symptoms. So what we often see is this intense high fever, often, or very, very often it starts with a bad headache, or body aches, high fever, fevers and chills, and that will go away by 3 or 5 days, but then you still continue to have these episodic low-grade fevers and more of an inflammatory type phase where you have all over body aches, or it settles in your lungs or your head or your bladder, and it's an inflammatory picture. So that shifts. Then I use a lot of things to treat anti-inflammation. So that's outpatient. It seems to be just more miserable for people. And I would say if you're going through it, number one, I would say be prepared, have stuff ready, and be prepared. I know I preach that. I've preached that over and over on your show and others, and I would say it again still. And number two, if you're in the middle of it, just know it gets long and it gets in your head. So, we've been told to isolate. We've been told, that everywhere you look, everybody's like, it can kill you. So it gets in your head that you're dying and you're all alone, and, nobody likes to be alone and miserable. And so those days get long. And so I think it becomes a spirit thing where you have to really do things actively to keep your spirit up to fight things off, because it's a well-known fact that if you can keep your attitude positive, that you heal faster. So, meditations, lovely music, anything, book on tape, that's an antiquated way to say that, but an audiobook, anything to kind of occupy your mind. And if I preach this too, if your household members have already had it, you're not going to re-expose them. So you don't necessarily have to while away in misery all alone. You can have company. Once you become immune, you're immune. If this thing were a double infection type thing, then it would be a whole nother animal. So.
Right. That's the other thing where, it's so funny watching what's been going on in the news lately, where it's like, just the last few days have been crazy, because the CDC, of course, changed their whole recommendation in terms of isolation and quarantine. Suddenly they've taken it from 14 days originally, then they brought it down to 10 days, and now they're back down to 5 days. And of course, all of the media that has been pushing this for so long, they're actually pushing back because they're freaking out, because they're like, oh my goodness, so we're all going to die because you've told us we're all going to die. So, but they're pushing it down shorter and shorter. And at the same time, they're also pushing this concept of, there was just an article I was tagged on earlier today on Twitter from Joe Ingles, where they were talking about, oh yes, you've had COVID before, you can still get it again. and Ohio is tracking them, those reinfections, except for they're not. I mean, they're just saying, oh, we're just going to add a brand new line, and there's no way at all to tell the difference between somebody who's been reinfected.
Yeah, they don't.
And it's just it drives me absolutely crazy, because it's like I had one story. One person came to me who and I get a lot of, I mean, not for medical advice, obviously, but for reassurance, because I can't even say the number of people who have contacted me in the last few months who have been very calm this whole time, and then they got COVID in this new kind of bizarre surge, and they get it really bad. I mean, it's serious. It's long, and it's this kind of, oh no, what do we do? It's really problematic. And one of the things is that these people get super sick months ago, to the point of going into the hospital with COVID, with real COVID. And then they come out again, and now they're testing positive. Well, no, it's not COVID. If you were so sick with COVID 5 months ago that you had to be hospitalized, you got better, so you clearly developed antibodies. There's no way that your body would lose that immunity over such a short period of time after such a severe disease. And yet they're testing positive. Why? Because our tests just test for a virus or segments of a protein. It does not mean, just because you test positive does not mean that you are infected or infectious. And it's funny, they actually, it was 2 days ago now that Dr. Walensky and Dr. Fauci came out there saying you don't need a PCR test to get out of your quarantine and isolation. Well, because PCR tests will last up to 12 weeks. I seem to remember many times, with you on as well, where I said exactly that, because the studies had been done in spring of 2020 saying that, but they only are acknowledging it as of 2 days ago.
Yeah, I've had patients swear that they've had it twice too, and not actually just test positive. I'm not sure all you said there because my dog was freaking out. Sorry about that. But but also, actually be sick twice and just swear, that they have had it twice. Which I would argue probably one of them was the flu, even with a positive COVID test. But if you're applying common sense here, which is so rare these days, if this were something that you could get again and again, then nursing homes, for instance, or group congregate living would be decimated by this, and it's not. So that right there is just proof that that's not occurring. So I talked about outpatient setting. In the hospital, we are definitely seeing cases still, and there's a decent amount. I don't know numbers. I can tell you what I'm seeing clinically at my own hospital. We see a lot of people who are there to rule out COVID, which always makes me smile because the waiting rooms are full. They're not moving fast because there's no bed movement in the hospitals. And if you're there to rule out whether or not you have COVID and you're sitting in a waiting room with 12 other symptomatic people for 7 hours, you probably have COVID.
You'll have whatever else everybody's got too. Is there flu sitting around there? Is there some kind of a rhinovirus? Oh, you're getting them all. You're getting them all at once while your immune system is already working hard with whatever you actually do have. I mean, it's
a lot of people, though, just show up to get PCR verification for a job or a trip or whatever, and so that's part of it. Anyway, that always makes me smile. But there are people who are getting sick still. I would say the amount of respiratory illness that we're seeing during this viral season is not worse from my perspective than we see on any given year for the flu. The difference is there is no staff. There's no nursing staff. And so there's no beds available because there's no one to care for the patients that would go in those beds. And then We're still using antiquated medicine with remdesivir, which guarantees that a patient has to stay in the hospital for the full course of those IV days, and that drags things out. So the ER beds have become boarding beds, which means there's no movement in the ER. And we're basically seeing patients in the waiting room, which makes everything look really full when really it's just bad plumbing. So
yeah, the staffing issues. I mean, so how is the staffing issue at your hospital there? Because we've been hearing, of course, in the news about Cleveland Clinic has been one of the worst offenders of this with pulling out full page ads, and where I am here around Cleveland, it's been ridiculous. You turn on the radio and you will hear the commercial talking about you need to care as much as we do, and on and on and on about how terrible COVID is, and they're overwhelmed with it. And I just got a screenshot of some of the internal memos in the Cleveland Clinic where 3,000 of their, this was, I believe, last Monday, 3,000 of their healthcare workers are out with COVID. The vaccinated, boosted healthcare workers are out with COVID.
Yeah, we just had similar incidents at our hospital last week. I think the number was 67 healthcare workers were out with COVID.
Out of how many? I mean, what's
I don't know how many we employ, if I'm being honest. But that's a big chunk of our staff. And I heard that the National Guard was being deployed to Mansfield and some other hospitals, which they made it sound like it was because the COVID cases were so high, when in actuality it's because the staffing is so low, because we're kind of begging, we're borrowing, what's the phrase? Borrowing from Peter to pay Paul.
Oh, yeah.
So many nurses are getting better pay to go agency or travel, or go into like a nursing kind of like pool where they can get distributed different places throughout the hospital, that we don't have like base staff anymore. And hospitals are paying out the nose for agency and travel nurses instead of, so it's just creating more of a problem that was started, as we've said ad nauseum, way back when all of this COVID first hit, and we shut things down and shut down ambulatory surgery and just took the hospitals out at their infrastructure, which has never been allowed to recover. So a lot of people left healthcare. They're not coming back. It was worsened by the mandates. They're not coming back. And here we are with short staff and a lot of respiratory patients. One thing I would like to talk about is I get a lot of questions about people. What starts to happen at home is you drop your pulse ox a little bit, and then at that point, you need oxygen, and it's tough to get oxygen as an outpatient without going through the ER. So when you go to the hospital and you come through the ER and you're COVID positive and you have some pneumonia on your chest x-ray and your pulse ox is low, then they want to admit you to the hospital and start remdesivir and start dexamethasone. So a couple of things I'll say about this. Number one, a lot of hospitals have the capability now to send you home on oxygen if it's 6 liters or less and it's not high flow. So there is that possibility to ask. There's a motivation from upper management down to admit patients because there's a monetary incentive there. This isn't news to this crowd. And there's a motivation to start remdesivir from top management down because there's incentive there. There's also motivation, obviously, to intubate. So I shouldn't say obviously, but we've been talking about this for a long time. If you find yourself in the position that you or your loved one is dropping your oxygen saturation and you're scared to go to the hospital, what I would say is just because you go to the ER does not mean that you can't still direct your care. Sometimes I've heard horror stories, and all I can do is apologize on behalf of my colleagues, but you can insist on things and you can be a jerk for yourself or for your family member. I mean, sometimes it's warranted, especially in potential life or death situations. And I know we've grown up in this paternal era of medicine where your doctor knows best, but we know more than most physicians right now. I guess I'm in both categories here, so that's weird for me to say, but but I just had recently one of my patients come to us late, like 10 days in, and she already was dropping her oxygen saturation. There was nothing I could do for her. So I asked her to go into the hospital. She refused remdesivir, and I was talking to the intensivist about her, and he was telling me how she was, a trouble patient for them. And I was just like, you're a respectable guy. We have a great rapport. You're one of the most brilliant people I know. Tell me more, And so we actually ended up having a really good conversation, and I recommended the book, The Real Anthony Fauci by Robert Kennedy. I would recommend that to anyone, especially any physician who's willing to read it. Please, please, please read and share that book. It is a wealth of information that just lays it out like breakfast. And there's no two ways about it. There's so many lies around this. I mean, we all know it's maddening, but it really, I think the beauty of that book, which I'll say this, anybody who ever hears me talk from here on out, I'm going to keep talking about this book. The beauty of it is that Bobby Kennedy is a Democrat, and we have polarized this into political things so much that we are missing the mark. And to have it come from a Democratic perspective, some of the ways that he lays things out and some of those statements that he makes and how he backs them up, anybody can hear it from either side. So I think it's really an important, it may be the most important book of our lifetime, quite honestly. So anyway, I offered this intensivist this book, and he was pushing back with me a little bit, and I was talking in particular about remdesivir and telling him how terrible it was and that it should never been approved, and then we got onto the conversation of outpatient treatment and why it's just being ignored. But the last piece that I'll bring up is monoclonal antibodies. This is technology that's been around for a long time. It's virtually without side effect. It has had profound clinical effect in my patient population, and the statistics are proving that out across the nation. It's not being promoted, and it's kind of being actively suppressed, like so many other things that are helpful. And the thing about it, I could go on about this, but where I want to start is that the thing about it that is maddening is the FAQ on it is that it is designed, it was studied to help keep people out of the hospital. So once you come into the hospital, you no longer qualify for it, which is...
There are some that you can, as far as I understand. There's like one kind that you can still inpatient, but it's limited in who can access it.
Largely, they will tell you no.
They'll tell you no, but that's
largely they will tell you no. So again, you have got to be an advocate for yourself. Most places, top-down directive will say that once a patient's admitted, they don't qualify for it anymore. So you have to kind of be adamant and say, fine, then give it to me in the ER before you admit me, and let's do this now. Where I work, they just came out with a memo saying that because the monoclonal antibodies that are out right now are not effective against Omicron, which is a lie, that they, there's a new special one. I'm sorry, I can't remember the name of it off the top of my head. And there's limited supply from the government. So we won't be offering it at my facility anymore, which is a tragedy, in my opinion. That is something that can truly save lives and turn people around. So again, if you find yourself with bad outpatient symptoms, ask for it. Ask your primary doctor for it. That is something that even mainstream medicine, vaccine touting, really pro-mask doctors will still write for.
One of the things that I've been hearing of over the last couple of weeks, particularly over the last couple of weeks when all these people are testing positive, again, positive does not mean infected, and there's definitely at least one or more other viruses going around, so people are freaking out, and they're steeped in it. It's up in their nostrils and they're in the mucus, and so they're testing positive and they're freaking out. Is that exactly what you were saying there, where they stopped giving monoclonal antibodies. I don't know how many people I've been hearing from who are, they know this. They know, okay, I'm sick. I'm genuinely sick. Well, I need to go get some and tested positive, and I need to go get some monoclonal antibodies. And they're told exactly that. Oh, we don't have any. You can't have it. It's not there anywhere. And exactly that, where they just don't know. You have to advocate for yourself right up front. And they're using
a lot of arbitrary rules. I mean,
yeah,
for it in different places, and some don't even need a doctor's note for it. Some you have to like be within specific parameters. Some will give it to even younger patients without even really any comorbidities, which is how it should be. If you're sick and you have decent symptoms, go ask for it.
Yep. I mean, in the state of Ohio, as far as I understand, you have to have a script. You have to have a doctor write a script for it. And you have to meet certain criteria, but the criteria are pretty limited. I mean, you have to be over
across all hospitals. I mean, I've really only written for it in Ohio, and like Wexner Center, for instance, I did one there, and they didn't even need paperwork from me initially.
Yeah.
Then I think more recently they did. I haven't done very many down there because it's kind of out of my area. But at my local hospitals, each one has different paperwork. Each one has different criteria. The one thing that's consistent, I would say two things, is a positive COVID test and within 10 days of symptom onset. So if you have those two things, then I would go ask.
Well, and not only just ask, demand as well. I mean, that's the thing, where if they're trying to give you the runaround on monoclonal antibodies, and you've got those two things, you've got a positive test result, and you've got symptoms within those first 10 days, as far as I understand, they really cannot deny you. So if they're denying you, fight. But that's actually another question to you. I mean, how does one most effectively advocate for themselves or their loved ones in a hospital situation in a non-antagonistic way? Because you don't want the doctors being antagonistic with you, because that's gonna create problems for yourself, and you're not asking anything unreasonable to get monoclonal antibodies. It's not like
none of this is unreasonable, but I've heard horror story after horror story of, as soon as you say you're not vaccinated, that you're treated like a second-rate citizen, or as soon as you say you don't want the treatment that they're recommending, specifically remdesivir, which is an awful drug. It is literally killing people. Never, under any circumstances, take it. If you know nothing else, just say no.
Yeah.
It was declined to use to treat Ebola, if that tells you anything. It's better to have Ebola and bleed to death from your eyes than take this drug.
That's a great way of putting it right there. I mean, it's better to have Ebola than use remdesivir. That should be a clue in why we should not be using remdesivir, and that's what everybody's being shoved on, and it's unreal watching it happen. And so, I mean, do you have any tips for how to approach the situation?
It can be really tough. I mean, you can start by asking. I always talk about the horror stories because they're mortifying to me, and I'm mortified on behalf of the patient, and I'm mortified on behalf of my colleagues, and I just can't. I would never treat a dog the ways I've heard some of my patients and just people in general telling me stories have been treated. However, you can't be afraid to ask. And there are plenty of healthcare workers out there who will not act like a jerk, even if they don't agree with you. So, just ask first and foremost. Be brave, ask. And secondly, it doesn't really matter showing facts or quoting studies. I think that, unfortunately, in my profession, you run into egos, and there's not really much you can do. But I always say, just kill them with kindness over and over. Just say, I'm just advocating for my loved one. You know, I'm not trying to offend you. I'm not trying to offend you. You can keep saying it over and over, but you know, from everything I've read, this is not what we want for our family.
Well, okay, so yeah, we can kind of go into this question here as well. Remdesivir is not a monoclonal antibody. Remdesivir is an antiviral. It is it is a pretty nasty drug. It's
basically poison. I mean, they designed it to treat Ebola, and it didn't work. It didn't work as recently as 1 month before they approved it to work for COVID. They shelved it for its toxicity roughly a month prior to approving it fully for COVID and making it, what's the term, like the standard of care. So once you make something the standard of care, then it becomes the liability of the hospital to administer it in a given diagnosis, and they get monetary kickback. So remdesivir is basically poison.
It shuts down your kidneys, and a lot of the when you hear about the whole COVID progression, a lot of that progression has to do with the administration of remdesivir and then putting them on the vent. It's crazy that we're still talking about this, where it was known. It was known
months ago. Yeah, it's been for a long time. So, and it mimics aggressive end-stage COVID. So there's no way to determine which is promoting that death. So it's really quite safe to assume that in the beginning, you know, when we were having tons and tons of organ failure and progression to fulminant sepsis, that a lot of that was the contribution of remdesivir being administered and aggressive intubating, because as we backed off on some of that, you know, against doctors' wishes, inpatient, I probably didn't say that right, against the directive from management, it's proving out.
that since more people are demanding things like monoclonal antibodies and rejecting remdesivir, those that do so, that get the monoclonal antibodies and say, no, you are just going to give me oxygen and give me supportive care and even nothing else besides oxygen and supportive care, they do better than those who end up on remdesivir. Is that what you're saying here?
Yep.
And to the point of what you were saying with the financial incentives, I mean, this one blew my mind here. It's right on out there. Let me see if I can get it up. This is from CMS.gov. Medicare COVID-19, new COVID-19 treatments, add payment. And it's written right here. I mean, if you are a hospital and you have a COVID code, diagnosis code, which in Ohio, at least, I know it doesn't even require a positive test. It just needs to be the clinician saying that it is COVID. You don't even need a positive test to be called COVID in Ohio. And so if the doctor says you're COVID, with or without a test, and they administer remdesivir, then the entire hospital bill gets a 20% add-on payment. And it's just like, we've all known this, but I mean, when I think it was Carrie that directed me to this website here, where it's written out there. It's right on written out there. The only other thing that could get that bonus is convalescent plasma. Well, anybody else notice that Red Cross isn't testing for antibodies anymore? I don't think they're taking convalescent plasma at all from anyone. I haven't heard of it for many, many months.
It's what keeps happening with these outpatient treatment modalities. They just keep kind of melting away from one regulation or another. So that's what's happening with monoclonal right now. I feel like they're trying to phase them out.
Yeah.
Or take attention away from them.
And using Omicron as the argument. I mean, I posted in my group, I think last week or something, or a few days ago, it was ridiculous because a lot of us watching it, the CDC was predicting, oh my goodness, Omicron is the dominant variant in the United States, and it was going to shoot up from like 20% to 75% in 1 week. And anybody who follows how viral evolution and transmission and all that kind of stuff is looking at it going, that's not how it works. That's insane. I mean, how is it possible that the entire country could just literally overnight flip over? This makes no sense. But the CDC was predicting it for a week, and then they updated the nowcast from that 75% to, well, actually, in reality, it's probably like 15 or maybe 20% of the prominence, and that was what they were using to argue that monoclonal antibodies shouldn't be given because it doesn't work with Omicron. First of all, that's already fake.
It's just a straight up lie. Monoclonal antibodies are not specific, so they would cover every strain, any strain, which is the complete opposite of vaccination. Vaccination is limited to the initial strain, so they're pushing that for Omicron, which is, it's already obsolete. It makes no sense whatsoever. It's like so many things in this entire process, it's the exact opposite of what is being.
They tell you, and this is actually one of those rare instances where they're actually telling you something that is straight out false. And because usually what they'll do is they'll tell you things that are
kind of
technically true, but are leading you to come to a false conclusion. But this one's one of those situations where it's like, well, this is the dumbest thing I've ever heard. This is insane. I mean, as you said, I mean, even with the vaccines, it's so funny because, and they're not vaccines, of course. They're so limited in what they cause your body to produce in terms of antibodies. And it's like, well, you don't want that limited. That's why Omicron exists, is because the vaccinated created it. Or I don't know if have you seen the phylogeny of Omicron?
Yeah.
Isn't that special?
I almost feel like something got re-released looking at that. I mean, and since we're there, since we're talking about it a little bit, would it be to make it more motivational for younger persons to get vaccinated?
I mean, there are a couple different things. I know I've had this phylogeny. A phylogeny is basically an evolutionary family tree. For those who don't know, and I had this. I've taken pictures of it because it's so incredible. So the story behind Omicron, which is highly suspect to anybody who's familiar with the evolution or just simply how family trees work.
Are you talking about the AIDS patient story?
No, I don't know that one. What?
Somebody proposed somewhere some absurdity came up that it was proposed that this that it like was laying dormant in an AIDS patient for I don't know whatever, and then that's where it came from. Which
exactly.
I just laughed and moved on. So I thought
right, but a lot of people don't understand this. That that the proper response to that story that they're putting out there is laughter because it's so utterly ridiculous. So with Omicron, when you look at the family tree of it. Its last common ancestor with any of the viruses that are out there is A1. That's the last time that they can follow the connection back. So all of the Delta, no relationship. Gamma, all of these have no relationship to this new strain. It came out of nowhere, like it basically was frozen in time, but at the same time, the mutations that existed make zero sense. in evolution, the way it works is you have natural variation. I mean, especially in RNA viruses, they're bad copiers. That's part of their charm, is that they're really bad at making copies of themselves, accurate copies of themselves, which allow them to mutate rapidly. And when they have this change in genetics, it's random. There'll just be random parts of the genome that will change, both functional and non-functional parts of it. So you can kind of, as a phylogenist, you can kind of look at those non-functional changes, that it doesn't actually create any difference in how the virus acts. And you can follow those changes through time. And that's how you kind of know how things are related, because that doesn't affect how it spreads. And then there are functional changes, which does affect how a virus spreads. It might make it more virulent. It might make it more contagious. It might, whatever it is, that it changes some functionality. That's what evolution can work on. Evolution can't work on these changes, these random changes that don't create an effect. So those will just go on at random. The thing about Omicron is, first of all, for last common ancestor was way back at the very beginning. And the second weird thing about it is the changes in the genome were mostly functional changes. And that, first of all, is very weird, because functional changes can be both positive and negative. They can promote the virus's replication, and they can also reduce it. And when this happens naturally, you should have a whole bunch of useless mutations, non-functional mutations going along for the ride. And the other weird part but we don't see that. We see pretty much all functional mutations in the spike protein, and very, very, very few non-functional changes along for the ride. Already just like, okay, that's weird. That should not be happening at all. It was like in a time machine, and then it magically appeared with all these changes that are just perfect. Mm-hmm. And it also, specifically for that story about the AIDS patient that was incubating it for so long, well, the interesting thing is those functional changes were almost all in the spike protein, which really strongly points to one of two things. Either we'll take the AIDS patient's story, but that would mean that it was this person had taken the vaccine, because the pressures so specifically on the spike protein alone is just like, that's not happening naturally. That's not happening in absence of the vaccine. That's happening with the vaccine. Or somebody went and did some gain of function on it, because there had to be some absolutely massive and fast evolutionary pressures to create Omicron. There's no other way around it. It's I
mean, you would know this better than me, but even messing with nature as we are by vaccinating during active infection, this is still to a level that makes no sense.
Yes. I mean, yes, I expect this kind of stuff to happen. You expect, especially when you're vaccinating billions of people with the exact same antigen, so they produce the exact same antibodies. You're going to have the exact same evolutionary pressures on the virus, and it's going to mutate away from it. But when it does mutate away from that, there should be the random tag along mutations going along for the ride. You should not see what Omicron has, which is pretty much all functional changes, no non-functional changes. This is a product of somebody put massive selective pressures on this virus at a very short period of time, and it's like, how conspiracy can we go? But there's really There's no other explanation.
You determine that you're being lied to. It's like staying with someone who's cheated on you, right? Like you start to look for signs that it's still going on. So it makes you wonder what else. But
this one, to me, it just blows my mind because it's just like just looking at it. It's like this is impossible. I mean, this is not natural. I don't know what they were doing, or if we want to, call the AIDS patient is the issue. Well, that AIDS patient was vaccinated in order to create those kinds of conditions, and it was not over a long period of time. That is very clear. This thing did not evolve slowly.
Anyway,
but as to what purpose it would serve to do that, I mean, the fun part about Omicron is it's so low virulence. It is so contagious. It has a low virulence. It basically is a natural vaccine. I mean, this is basically smallpox and cowpox. I mean, it's similar kind of functionality here, where cowpox, you infect somebody with cowpox and they develop an immunity that works against, they develop minor symptoms, but an immunity against smallpox. And that's basically Omicron. But at the same time, it specifically infects the vaccinated. So it's just like, what's going on here?
Yeah, if you're going down that rabbit hole of feeling like maybe this was intentional or a new release, then my next question is why? And I couldn't quite connect the dots there in my head, if I'm being honest. So.
I mean, there's a couple reasons why, but it's just like, I don't know. I mean, it's all I can say is evolutionarily, Omicron makes exactly 0 sense. That's no. Mm-mm. And the AIDS patient,
yeah, that actually made me laugh out loud. So I guess from my end, what the things I wanted to talk about today are to just reassure people that this, the narrative is not so terrible as you hear. Yes, hospitals are crowded, but it's not because the case count is so high. This looks like most viral seasons to me. Early treatment is paramount. There definitely are people who weren't having aggressive disease before that are now, and I cannot emphasize early treatment more. And second of all, if you find, or lastly, I guess third, if you find yourself at home sick and afraid to go to the hospital, don't be afraid. Just know what to ask for. Ask to go home on oxygen if you're able. Decline politely remdesivir and adamantly if you need to. And try to get home as soon as possible so that you can actually do things that help you, like high-dose vitamins and things that they won't really allow you to take in the hospital. I would take them with you anyway and not ask questions. And so that you can be around your family, because a lot of hospitals still are not allowing anyone to come visit you if you're testing positive for COVID. And if you are alone and scared and miserable, it's really hard to keep your spirits up, which goes a long way toward fighting off illness and feeling better.
Yep, you get into that cycle of fear and anxiety, and then you're going to start feeling more ill, and then you're going to actually become more ill, and that's kind of one of the things that has driven me nuts about this whole process, is because everything that they have done is it all sets us up for that anxiety that just can't go away, and it's actively promoting the worst possible health outcomes, and for no good reason. It's not like, we just have to be reasonable, exactly what you just said there. So there was a question up here in terms of I think you kind of answered this here. Please don't use remdesivir. Please give me monoclonal antibodies or go home, or what.
Push for monoclonal antibodies. If you're at a facility where you can't get them because they just don't have them, then you can certainly ask to be transferred. I can tell you transferring is tricky these days because everybody's full. So there's a lot of pushback. But that I would be advocating for monoclonal antibodies, advocating for ivermectin if you haven't been on it. And things that are safe and that I would accept are dexamethasone or any type of IV steroid if it's something you can tolerate. If they want to give you antibiotics, that's fine. And the oxygen piece is really often what keeps people in the hospital. I guess another thing I should talk about is there is a component of blood clotting to this that we've known all along. If you're sick at home, two things. Remind me to go back to the sick at home, because I want to bring up something that I've become more of an advocate of recently. But if you're sick at home and you can tolerate baby aspirin, I would just take a daily baby aspirin to help from developing those microclots. Very often patients will test positive for something called a D-dimer, which is a screening blood test for blood clots. That does not mean that you have blood clots. It's a screen test. It's meant to be very sensitive, so there are a lot of false positives, and really that just goes on to say that you need to do some kind of chest CT or imaging to make sure that you don't have blood clots on the lung. And very often those are negative with a positive D-dimer in COVID. And COVID does trip D-dimers more often than people without a true COVID case, because there is microclotting that goes on. So sometimes people will be admitted because they can't get that CAT scan or something called a VQ scan or the imaging that they need to have done that night. And, they need to stay and get it done the next day in the hospital. So, but if you can go home on oxygen most times, you can go home on antibiotic, you can go home on steroid, and you can go home on some type of blood thinner, even as low as a baby aspirin. So once that has been ruled out, then again, I would advocate and for yourself and ask, what do I need to do to get out of here? And can I go home on oxygen? Can we set that up? Let's get the caseworker involved. Let's get things arranged so that I can go home on oxygen if I still need oxygen.
So what would be the reasoning for being in the hospital? I mean, what would be something that the doctors would say to you? You need to be admitted because XYZ, because obviously oxygen is not, and treatment is not necessary in the hospital for the most part. Any drug treatment, it sounds like, isn't so necessary to be in the hospital. So what reasoning would the doctors give you that you should say, yeah, okay, this is a reasonable reason to be admitted?
If you're requiring higher levels of oxygen, like high flow, or BiPAP, higher levels of oxygen, or if you are testing positive for a D-dimer, you're there with a significant shortness of breath and they don't have a way to do imaging studies to rule out a blood clot on your lung, that would be a reason to stay. If you live alone and you don't have family support and you really are, quite nervous that you're not going to do well, that would be a reason to stay. More hospitals are trending toward this, but not every hospital has the capability to set you up with oxygen that day or that night, especially if it's a late, like 1 o'clock in the morning or something, to send you home on oxygen immediately. So sometimes they'll admit you until those arrangements can be made, which would also be acceptable. It's okay to get an IV dose of dexamethasone or antibiotic and then ask for orals for home. You don't gain much IV there with this scenario, or really anything at all. So I would say reasons to be admitted would be a positive D-dimer without imaging to be able to rule out a blood clot on your lung, or requirements of high flow oxygen, or not a lot of support at home.
So here's another question for you, besides the baby aspirin.
Yeah, so there are people with allergies, and there are some natural things that thin your blood, like omegas. I kind of jokingly call those nature's aspirin. You can use some high dose omegas. I'm talking about omega fatty acids there. And then, why am I drawing a blank? There are other prescription medicines like Eliquis and things like that. I don't know that I would go to that extreme if I didn't have an actual blood clot on my lung. So I probably would just reach for healthy fats.
Another question there. I actually got this question before as well.
Ivermectin is safe in nursing and pregnancy. So is hydroxychloroquine. That's been used worldwide for years. That's not me talking. That's the data.
All right. I don't know if I've missed any questions here. So if you guys have any questions that I missed and want to post them again, I can get them here. We can have our answers.
Let me finish by saying that personally, I am not on Facebook anymore. It went to Meta, and I am out. So
I've been in menopause twice. 30 days in jail. I don't know how I managed to squeak through without a third menopause, but
that's hilarious. So if you're trying to reach out to me through Facebook Messenger, or you've sent me something, it's not a slight. Personally, I'm just not there anymore. My personal page is still standing, and my business page is still standing, and it's managed by one of my staff members. So if you're trying to reach me, the best way is through my office. So if my point is, if there are questions posted here later, Catherine will have to get them to me, and I'll get you an answer sort of roundabout, but I would love to help. I just am not on Facebook or any social media anymore.
No, freedom.
I know, it's been a really good thing for my personal health. I'm not going to lie. The local election helped further that decision for sure. It got really ugly here. So,
well,
school board people, it's a school board seat. 1 to 5. Anyway.
All right. So we got a couple more questions here.
Yes, that is very possible. Thank you for asking, Renee. I know you know the answer to this. There are physicians out there who are willing to prescribe. My office definitely prescribes. I love to do it prophylactically and have you have the tools. You can use it as prophylaxis, or you can sort of squirrel it away and use it for acute illness. But yes, it's out there. There are pharmacists willing to fill and doctors willing to prescribe. We're one of them. Elite Wellness Group, elitewellnessgroup.com. My office number is 419-602-0293. We are on Facebook, Elite Wellness Group. And
well, yeah, I guess you're not on Facebook, so I'll have to take that down and put it into the comments afterwards.
Yeah, thank you. But yes, I'm not the only one. There are more docs around Ohio, and there may be some in your area. You can always start by asking your primary doctor. Just don't be offended when they say no. And hydroxychloroquine, is largely fallen out of the conversation, but it's still really a good drug. And especially if you're someone, I've been saying this for a long time, I'll repeat it again. If you are someone who is altering your behavior out of fear, and you're not doing things that you want to do because you're, afraid of contracting illness, then it makes sense for you to be on something prophylactically. And in the prophylactic phase, I usually tend to encourage people to do hydroxychloroquine over ivermectin, just because it's a little cheaper, it's a little easier to get your hands on. Typically, it depends on the week and the day sometimes. And it's easier to get a higher, more supply of at once. So, you can kind of get some months worth and take it without interruption. The supply for ivermectin kind of waxes and wanes sometimes because I'm largely reliant on compounding pharmacists who have been amazing. There's quite a few I work with, but they have limited raw materials that they get sort of allocated to them. So I'll have them run off and on. And there's nothing more frustrating to me as a clinician when I know the tools that someone needs for help and I can't get them to them. So ivermectin is a piece of it. Hydroxychloroquine is a piece of it. There's more to it than that. But yes, the answer is yes. Have that stuff at home in a kit ready to go. The other thing I wanted to talk about really quick, I've become a big fan of Lugol's iodine or betadine. If you're somebody who does sinus baths and you're mixing up a neti pot and you put just one drop in the neti pot and do a sinus bath with it. If you are somebody who works, with the public, or like I walk through COVID all day long on Mondays when I'm in the ER, or you've been exposed and you're starting to get that tickle, it stops viral replication on contact. So it's gross. You have to sort of snort it up your nose and let it run down the back of your throat. Or if you can't do that for whatever reason you have an aversion, and you can at least like gargle and get it back in your posterior pharynx, and do that, every few hours while you're awake. If you're aggressively trying to stop an active infection from setting in, it's effective, it's cheap, there's a lot of gain for the, sort of pain or what you're doing.
Well, yeah, and probably I would assume it would also help with some of the not false positives on the PCR tests that we're seeing right now that are not actually due to infection or spread or anything like that, but just simply it's not up your nose and it's filled with it's filled with what you've been walking through all day, and I think that's a lot of what we're seeing in this surge. And I would imagine, if you irrigate your nose, especially with something where it will stop the viral application, I would assume it should probably help with that too, with false positivity.
I think I said this last time I was on. The solution to pollution is dilution. That's something that we got drilled into our brains during surgical rotations in medical school. And if you have a contaminated field, flush it, and it's the same kind of concept. You're clearing out all that dead particle, and just the dilution itself helps clear viral load. So absolutely.
And it's so simple and stupid and stuff, but at the same time, that's I think one of the reasons for this last surge has to do with the increased viral load that's out there, being because of course the vaccines don't actually prevent people from being infected or people from spreading it. It just reduces their symptoms, which allows them to go out into the public with a much higher viral load than anybody has ever experienced.
All over the place. Yes. Yep.
So people who never got sick through the entire time suddenly have gotten sick now, and as you saw, that there tend to be younger, healthier people who never had any problem, but they're really getting sick. Why? Probably because it's not the strain, it's the fact that the viral load that they've been exposed to is so high. So doing something like the irrigation would probably help quite a lot in preventing that kind of issue of overwhelming viral load. Right? And of course, the ever important question.
Thank you for asking. The short answer is yes. We are saving emergency appointments and prophylactic appointments intentionally so that we can help people in real time. We took some time over this holiday week here to kind of revamp how we're doing things, because business changed hard and fast, and we've been sort of reacting, and now we're trying to get more proactive. So we have new patients, hopefully room on the schedule for that routinely. And then new patients, as far as my actual practice of functional medicine, I think we're booking out to March right now. So the long answer is yes, but you may need to be patient, and I would love to help you.
Well, that's a good problem to have for you. That's definitely a good problem. So there's a lot of questions over here about more specifics in terms of what to use in an neti pot, if there are spray nasal bottles you can use, all that kind of stuff. Is there any resource online that can kind of
Yes. Give me one quick second, if you can hold the crowd for a second. My dog will not quit barking, so let me just let him in really super fast. I'll be right back.
All right, so I guess I'll try to talk to myself, which I'm not very good at, to find what other kinds of questions there were. No, I think that's most of the questions at this point are questions about exactly that, what to use in terms of sprays, ingredients, neti pot, all that kind of stuff.
So there's a xylitol spray out there that is a nasal spray that's pre-made. You can use that kind of prophylactically or routinely. Good old-fashioned Listerine, gargling with Listerine is a good sort of routine prevention. Neti pot is just, I don't know anybody out there that uses a neti pot. You just kind of, it's usually a saline mixture or just hot water, and you literally kind of drown your sinuses in it. So I'm talking about just You can either use Lugal's iodine, which is, I believe, 3%, and it's available at most health food stores. You can use betadine, like you would clean a wound with, or I've heard hydrogen peroxide. I don't have as much experience with that. And just a drop in a neti pot, which is like the size of a coffee cup, basically. And you then can either squirt it up there, or like with the neti pot, you just pour it with gravity. So it's not like you need anything fancy. I'm pretty neti pot savvy, so that's kind of the analogy I use and the thing that I use and recommend. But I've heard other docs, you can use just like a Toomey syringe from a hospital kind of setting and squirt it up there, or I'm sure like a dropper that you would give a child medicine with if you tip your head back and squirt it up there. And the idea is to get it in your nasal cavity and let it run down the back of your throat, which is disgusting, but simple fix.
So many questions about it too as well. Here's one that's slightly off the neti pot land.
Yeah, great question. The loading dose is the same. So it's 200 milligrams twice a day for 5 days. And that's for acute treatment, meaning if you're sick with symptoms, 200 milligrams twice a day for 5 days. And then if you are going on then to prophylax, you load 200 milligrams twice a day for 5 days, and then you take 200 milligrams once a week.
All right. So one last thing actually for me to ask you as well, because yes, there's definitely going to be questions coming out of this one. So what is the best way to reach you with those kinds of questions, the more simplistic ones? Is it still just calling your office and hoping to get through, or?
Yeah, unfortunately. If there's a few more here, I have about 5 minutes left. I could keep answering them. I'm not really. I do have a website, drelizabethlaffay.com is still up. And there's, a couple things on there as far as my testimony and stuff, but the link is mostly to my office. So
yeah, I'll have my website, because of course I'm being horrible. I mean, I'm on my third group here on Facebook because they like to shut me down. And so I've got a website under construction that's going to have all the data that I've collected, all of the tutorials, all of those kinds of things. And I mean, yeah, if you want, I could definitely put a section up there where it's a little more, concentrated or whatever, have it live in a space. Because I mean, these questions are just going to keep coming up, and it is one of those things where I get a lot of the questions, and I'm like, I don't know.
Yeah. We should probably try to do this a little bit more routinely. I struggle with free time these days. I'm not going to lie. I feel nice and relaxed today because I've had family in town and a couple of days off here. But yeah, I struggle with free time for sure. And I start the school board next week, which should create more time in my life.
Especially when OHA has so kindly and thoughtfully created a nice little stir for you.
Yeah, it should be good. I love things.
When people like us are the rabble rousers, society has gone the wrong way.
Right. It's really well said. Really well said.
Well, thank you, Beth, so much for coming on with me, and I'm always open. And whenever you want to do anything, I will happily have you on, whatever you want to talk about.
Thanks. Good to see you as always. Thank you, everybody, and until next time.
Well, and if nothing else, I'll see you in 22 days.
That's right. I'm looking forward to it. Happy New Year. Happy New Year, everyone.